this our cardiac surgery group. With great pleasure, I want to introduce my colleague, Dr. Tessa, who's been our colleague for the last 3 years. She came to us from the University of Michigan. Just to give you a little bit background about about Dr. Watt, she did her undergrad at Stanford and then spent a little over a decade at our Big Ten rival, the University of Michigan, during which she had several accomplishments, completed a medical school, did a master's in healthcare research, was one of the first, I believe, completing an integrated thoracic surgery residency, in which she also served as chief resident and subsequently did a fellowship in advanced heart failure and valve surgery at the University of Michigan. At that time, she also trained with one of the modern-day pioneers in mitral valve surgery, Steve Bowling, who we've all had a pleasure of meeting and hearing him speak on mitral valve surgery. What my highlight about Tessa are the following. I've had the pleasure of meeting her family. Her husband, Will Peterson, is an emergency physician at the University of Minnesota and at Hennepin, and also the pleasure of her meeting her two lovely daughters. Mostly when I hear them in the background on the phone when I'm talking to Tessa, Sophia and Lily. But most importantly, what impresses me about Dr. Watts, and this has been a lesson to me and should be to our fellows and residents, is her professionalism, her thoroughness, her detailed approach to everything. If Tessa and I are discussing a patient and I ask her any detail about the patient, she knows everything about the patient, and this should serve as a reminder to our fellows, my colleagues, myself, and our general surgical residents. It's not often that when I talk to a fellow or a resident about a patient and I ask, what's the lactic acid or what's the x-ray, they say, let me check. And more importantly, I say, how does the patient have any abdominal pain? To stay on our current theme. And then still, let me go into the room and check. So when you're talking about a patient, it's a reminder to us to be very thorough and detailed in knowing everything about the patient, because that could save a patient's life. Tessa, you have brought many techniques from the University of Michigan that we now follow. For example, your aortic repair, and I'm not going to go into details, but when I'm with any of the fellows, I say, okay, we're going to do it the Tessa way. It's a lesson for us in academia to be open-minded to learning new techniques and incorporating all those things into things that will improve our patients' outcomes. So thank you for all that you do for our program, and we welcome you for these grand rounds.
Thank you so much for that extremely generous introduction. I'm super thrilled to be here today. So we're just going to get these slides pulled up. Yeah, as a younger faculty member in my third year, I'm very honored to be able to speak to you guys. Excellent. So today I'm going to be talking about a topic that I'm very passionate about, which is mitral valve repair. By the end of this talk, I hope that you will understand not only why it is interesting physiologically and technically and important for patient care, but also why it is timely and there's an urgent need for surgeons to remain vigilant in the face of growing transcatheter technology. I recognize this is a broad surgical audience with varying exposure to mitral regurgitation, so I want to start by explaining why this is an important topic. So mitral regurgitation is the second most common valvular heart condition in developed countries. Fortunately, mitral valve repair for degenerative mitral disease has been shown to restore normal life expectancy to patients with a very low operative mortality and incidence of reoperation. Within cardiac surgery, mitral valve repair for degenerative MR is one of the few operations that we can do that can be truly curative. And yet, it is grossly undertreated. Despite the clear benefit of mitral surgery over medical management for severe MR, up to 50% of eligible patients are not undergoing surgery. So taking a step back, what is degenerative MR? Mitral regurgitation can be broadly classified as degenerative or functional. Degenerative MR is a disease of the mitral valve itself, or the leaflets, where the tissue stretches out over time and becomes loose or redundant, causing mitral valve prolapse, a cord ruptures, causing a flail leaflet. Functional MR, on the other hand, is a disease of the ventricle, caused by either ischemic or non-ischemic cardiomyopathy. In non-ischemic cardiomyopathy, there's global dilation of the left ventricle, resulting in dilation of the mitral annulus and malcoaptation of the mitral leaflets. That etiology is depicted in this diagram by type 1 in the schematic of Carpentier's classification of mitral regurgitation. In ischemic cardiomyopathy, when there's ventricular scarring or scarring of the papillary muscles from a myocardial infarction, this distorts the mitral apparatus, leading to restricted leaflet motion, and that is represented by type 3B in this picture. There's also rheumatic MR, which is an inflammatory sequelae of rheumatic heart disease, which causes thickening of the leaflets and restricted leaflet motion, which is type 3A in this diagram. However, for this talk, I'm going to focus on degenerative MR, which is characterized by excessive leaflet motion, and that's depicted here by type 2. With functional MR, the underlying cause of the valvular issue is a disease of the ventricle, which means that even with mitral valve repair or replacement, surgery does not treat the underlying cause of the disease process, and these patients are still affected by their underlying heart failure. However, in degenerative or primary MR, the issue is the mitral valve itself. It's a spectrum of fibroelastic deficiency or myxomatous tissue disease, which can result in chordal elongation, chordal rupture, leaflet expansion, or annular dilation. These patients are often young and otherwise healthy, and surgical repair of the valve has been shown to restore patients to a normal life expectancy. And that is why it is critical to recognize and treat these patients early before they develop long-term sequelae of chronic MR, which is not always reversible. So this slide illustrates the natural history of degenerative MR. The plot consolidates data from multiple studies to depict the percentage of patients who are alive and asymptomatic without surgery as a function of time after diagnosis of severe MR. While many patients remain asymptomatic for years, the annual mortality for symptomatic patients is high, up to 34% for classes 3 and 4 heart failure symptoms, while asymptomatic patients with preserved heart function still face a 5-year risk of nearly 42% for developing symptoms of heart failure or atrial fibrillation. Death or need for surgery was almost unavoidable within 10 years of diagnosis. So, when do we intervene on degenerative MR? I'll briefly walk through the 2020 ACC AHA guidelines for mitral regurgitation. First, focusing on primary or degenerative MR. Then it needs to reach the severe level. And then the big differentiation is symptoms or no symptoms. If symptoms, then surgery. If no symptoms, then we look for signs of sequelae of MR, such as reduced heart function with an LVEF less than 60%, or left ventricle dilation with an LV end systolic diameter greater than 40 millimeters. If either of those is present, then surgery. If the function is normal and the ventricle is not dilated, then we consider if the patient has other sequelae of chronic MR, such as atrial fibrillation or pulmonary hypertension, and only proceed with surgery if the expected surgical mortality is less than 1%, with a greater than 95% likelihood of successful and durable mitral valve repair without residual MR. If that isn't the case, then you wait until there's a progressive increase in the LV size or a decrease in the LV function before proceeding with surgery. So basically, this means that we wait until the heart gets much sicker before it's worth the risk to proceed. So to summarize, for mitral valve repair, you wait until the patient has symptoms, or if they're asymptomatic, wait until the heart shows other signs of negative remodeling, such as reduced function with EF less than 60, pulmonary hypertension with PA pressures greater than 50, increased LV size with LV ESD greater than 40, or develops atrial fibrillation. And there's a mnemonic for this, 60, 50, 40 AFib. Unfortunately, all of these are bad and frankly too late. So this study by Gilinoff looked at over 4,500 patients who underwent surgery for degenerative MR from 1985 to 2008 and showed that higher preoperative NYHA class was associated with worse long-term survival. Unsurprisingly, higher NYHA class was linked with lower EF, as well as presence of AFib and tricuspid regurgitation. The bottom line is that the more preoperative symptoms leads to worse outcomes. This study by Enriquez Serrano shows that there's worse survival as a function of reduced preoperative ejection fraction. So the waiting for the ejection fraction to fall is bad, not good. This study by Tornio demonstrates the prognostic impact of preoperative pulmonary hypertension in mitral surgery. And here, PA systolic pressures greater than 50 was associated with substantially reduced long-term survival, with only 46.9% survival at 10 years after mitral surgery in the pulmonary hypertension group, compared to 86% survival in the group with PA pressures less than 50. So waiting for pulmonary hypertension is also not good. And finally, a couple more studies showing that preoperative AFib is associated with worse survival after mitral surgery. So waiting for AFib is also not good. Additionally, this study by Dr. Chikwe, published in JAMA in 2013, compared the effectiveness of initial medical management versus early surgery following the diagnosis of severe degenerative MR in patients with class 1 triggers for surgery, such as heart failure symptoms and LV dysfunction. They evaluated over 2,000 consecutive patients with flail mitral regurgitation compared to those who were initially medically managed versus those who had surgery within the first 3 months of diagnosis. They found no significant difference in early mortality or new onset heart failure rates. However, the long-term survival rates were higher for patients with early surgery, 86% versus 69% at 10 years, which was confirmed in adjusted and propensity matched models and associated with a 5-year reduction in mortality of 52%. Long-term heart failure risk was also lower in the early surgery group, 7% compared to 23% at 10 years. So now I want to shift to the next key concept, which is the importance of mitral repair over mitral replacement for degenerative MR. In mitral valve repair, we use a combination of primary leaflet repair and annuloplasty to treat mitral regurgitation while sparing a patient's native valve tissue. However, in mitral valve replacement, we resect some native leaflet tissue and replace the patient's native valve with either a bioprosthetic cow or pig valve or a mechanical valve, which each carry their own drawbacks and substantially alter the patient's life going forward, frequently resulting in the need for additional procedures in the future. A landmark study in Circulation in 1995 showed that mitral valve repair resulted in similar long-term survival for patients as their age-matched counterparts in the general population, whereas mitral valve replacement results in substantially poor long-term survival. Essentially, this means that successful mitral valve repair can be curative for this disease process. In 2020, I published a paper along with my mentor at Michigan, Dr. Bowling, looking further into how degenerative MR repair restores normal life expectancy for patients. We looked at over 1,000 mitral repair cases between 2003 and 2017 and categorized patients by age group in decades, asking the question if mitral valve repair could restore normal life expectancy at all decades of life compared to the general US population. We used Weibull probability plots and Anderson-Darling goodness of fit testing to show with high confidence that degenerative mitral valve repair restores anticipated life expectancy to that of the general population, regardless of age. Now that we've reviewed why mitral valve repair is so important and superior to mitral valve replacement for degenerative MR, I'm going to return to the guidelines that state for asymptomatic patients with severe mitral regurgitation and normal EF and LV size, it is a Class 2A indication for mitral valve repair if the expected surgical mortality is less than 1%, with a greater than 95% chance of successful and durable mitral valve repair without residual MR, and that's defined as moderate or more MR. So this is STS data that's a little bit dated, but it illustrates that mitral valve repair rates on the whole fall far below the guidelines of 95% rate of mitral valve repair compared with replacement. An update from 2021 does show that there's been some improvement to 65% overall repair rate, but this still falls far short of the goal. And notably, surgeons at mitral valve centers of excellence routinely achieve greater than 95% repair rates with less than 1% mortality, but the majority of these cases are concentrated among relatively few high-volume surgeons. Unsurprisingly, mitral repair rates are heavily tied to surgeon volume. The more you do, the better you are. And the key to achieving durable repair is to do a perfect operative repair and leave no residual MR behind. To summarize, mitral volume predicts the likelihood of successful mitral valve repair. Mitral valve repair restores life expectancy to patients. Life expectancy depends on a perfect repair, and surgeons should strive to leave no MR behind. So, how does one do a perfect repair? I learned this concept from my mentor, Dr. Bowling, that the competency of the mitral valve can be thought of as a Roman arch. Once the keystone is in place, it can withstand tremendous amounts of pressure and remain intact and strong for many years. In tribute, I had to include this picture of Dr. Bowling demonstrating this concept. This keystone is the zone of coaptation between the anterior and the posterior mitral valve leaflets. So how do we accomplish this? These are the core principles that I rely on for degenerative mitral repair. First is the review of the preoperative echo. So one key concept to understand about cardiac surgery is that the heart, and specifically the mitral valve, is very dynamic. We can study and evaluate how the components function together in preoperative echoes, but once the heart is arrested and we're doing the actual repair, the heart is still and empty. This means it's really important to study preoperative echoes and go into surgery with a plan for your repair, not only to minimize cross-clamp time, but also because it can be difficult to assess this intraoperatively. So these are some examples of different echo views and how they translate to the surgical anatomy of the mitral valve. Next, I'm going to talk about the critical importance of exposure of the mitral valve. So to borrow another quote from Dr. Bowling, this is the classic non-exposure of the mitral valve. And if you can't see it, you can't fix it. Unlike in this picture, where you can hardly see the posterior annulus of the valve, this is what it's supposed to look like. You should be able to see the anterior leaflet, the posterior leaflet, and both commissures. A key step for achieving the best exposure is rolling Sondergaard's groove, which separates the atria. And you want to roll the groove all the way until you see the white dot, which is the embryological origin of the connection between the left and the right atria. Next, you evaluate the valve. You can take a quick look for major valve pathology, but before doing too much, it's best to place annular sutures, which both lifts the valve up into view and it helps with your exposure, and it also simulates what an annuloplasty may do for the repair. So you place annular stitches and then evaluate the valve more. At this point, you can inject cold saline into the left ventricle to fill the heart and test the valve, and to help diagnose where the leak is coming from. And next, you perform the actual repair. There are lots of types of mitral valve repair techniques. All of them either involve a band or a ring, which can be done alone or in conjunction with leaflet excision, leaflet plication, leaflet patch, artificial cords, cleft closure, sliding plasty, or Alfieri stitch, just to name a few. One commonly used technique is leaflet resection. So this can take the shape of a triangular resection or a quadrangular resection with sliding leaflet plasty. In general, when there's less excess leaflet tissue, you perform a smaller resection. In contrast, in Barlow's disease, where there is an extreme amount of excess myxomatous tissue, you often need to resect more tissue, and there's more leaflet displacement. With any resection technique, it's important to try to preserve as many working native cords as possible and try to only resect abnormal cords in order to maintain the functional geometry of the valve and the ventricle and promote positive remodeling after surgery. The other key tenet of mitral valve repair is the use of neocords, or artificial cords, to repair flail or prolapse segments of valve tissue. One of the benefits of this is enabling a longer zone of coaptation, which can maintain normal leaflet motion, and also allowing for a larger annuloplasty ring. So why use a band or a ring? The concept is that annular dilation is like a broken rubber band around the mitral annulus. And in order to bring the mitral annulus and ultimately the ventricle back down to size through remodeling, there needs to be a durable reinforcement of the broken or stretched out mitral annulus. So this picture shows the end result of a mitral valve repair where the annulus is being reinforced with a complete annular ring. In order to select the correct ring or band size, you measure the AP height as well as the area from trigone to trigone of the valve. And here's a picture showing the sizer. So next, we test our repair. In order to test the repaired valve, we again inject cold saline into the left ventricle to fill the heart and test the competence of the valve. Again, this can be difficult to simulate in the setting of an arrested, non-beating heart, but you can often get a pretty good sense of the adequacy of your repair. You want to see the smiley face, which demonstrates a good line of closure where the posterior leaflet nearly disappears. And I have to say my husband, who is not a surgeon, could not see the smiley face in this picture, so I had to add this for his sake. You can also check the adequacy of your zone of coaptation, or how much the anterior and posterior leaflets are touching inside the ventricle, and that would be the keystone. Last, the intraoperative echo, once the heart is reanimated, is the final test of your work in the OR. And if the C is blue, the flow is true, meaning if the color of the left atrium on echo is all blue, then there is no leak. So I'm going to go through a couple of cases. First, we have a 62-year-old man with severe MR, posterior prolapse or rupture, normal function, and normal coronaries. So you can see in this echo, there's clear flail of the posterior mitral leaflet. Clearly, the leaflet is prolapsing above the level of the annulus. And you can see that this causes severe mitral regurgitation that's directed toward the anterior leaflet. And then you can see there's definitely not a blue C. You see a lot of red and yellow flow going back into the left atrium. This is a 3D reconstruction of the TEE showing more of a surgeon's view. So you can see here that is the part of the posterior leaflet with the ruptured cords flopping right into view. And this is a video that depicts, kind of walks through one of these repairs. So this is a ruptured cord that you can clearly see right away. But before we do anything or make any major judgments, we're going to place our annuloplasty sutures, which are these using 2O ethibond, or maybe surgeons use other stitches, basically going around the entire annulus. And it can either be the posterior annulus or it can be a complete all the way around both. And here you can see that putting in those sutures brings the valve into view. And now you can better assess where the real problem is. So this is the saline test, injecting saline into the ventricle, and you can see it shows the area the valve is damaged and there's ruptured cords. So now this is planning the repair. And the surgeon's going to be very careful to resect only what needs to be resected. So that area where the cords are ruptured has to go, but you want to try to leave as many of the working cords as possible. So some of those are going to have to go, but you want to leave as many as you can to preserve the geometry. Because again, the mitral valve is just as much about its relationship with the ventricle as the valve itself. And so in order for long-term remodeling, you want to leave as many of those cords intact as possible. So that was a triangular resection. And now we're going to do imbricating horizontal mattress stitches to connect the two sides back together. And I like the imbricating stitches here because it allows you to continue to resect more and sort of exclude more of the leaflet down while not removing it entirely. So you can actually preserve more cords this way without actually resecting the tissue. And so it's a nice technique. Sometimes you don't have to resect at all, and you can just imbricate and exclude a prolapse segment, and it will work. So then you carry these horizontal mattress sutures down the defect and toward the level of the annulus. Sometimes you can even test it at this point just to check your work, knowing that, of course, it's not perfectly hemostatic yet, but it gives you a sense if you're heading in the right direction. But here's the completed kind of last stitch going all the way to level of the annulus. And now bringing down the ring, removing the plastic, and then now testing the valve again with the saline test. So you can see the annuloplasty band is in place and injecting saline into the ventricle. The ventricle popped up, but there's nothing coming back into the atrium, so there's no leak there. So this is the post-echo for this case, showing no residual prolapse of the leaflets above the level of the annulus. So first you look in the anatomic view, and then after looking all the way around, turning the color on with echo and making sure there's no residual MR. And as you can see here, the C is blue and the flow is true, there's no MR. So case 2, this is a 68-year-old man with severe mitral regurgitation, bileaflet prolapse, normal function, normal coronaries. So in this case, you can see there's a key difference here. Both the anterior and the posterior leaflet are prolapsing above the level of the annulus. And there's different ways to repair this. Different surgeons will approach this in different ways. You can see that it is leaking. And here's the MR again. And this is the surgeon's view. This is actually, I jumped ahead. I'm not sure if anyone can tell me what type of repair was performed here. It's almost a trick. It's less common type of repair. So this is an Alfieri stitch. So for bileaflet prolapse, if the annulus is big enough, of course you don't want to cause mitral stenosis, but you can actually just basically take the two ends of the anterior and posterior leaflet in the middle and connect them with this budgeted stitch. And that will address the prolapse. So there's no cords, there's no resection. The key here is that you have a big enough annulus so that you don't have resulting mitral stenosis. So anything 36 or bigger is probably big enough to be fine. And this is a picture of the repair afterward. And it's that Alfieri stitch is something I'm going to refer to again at the end. So just keep in mind that was what that was. And you can see again here, there's no MR. And there was also no mitral stenosis. This is the third case. This is a 72-year-old woman with severe MR, also bileaflet prolapse, normal function, normal coronaries, but this patient was addressed in a different way. So again, you see both the anterior and the posterior leaflet prolapsing above the level of the annulus. And this is just a picture showing that you could consider still resecting part of the posterior leaflet. And then for the anterior leaflet, in this case, we chose to do neocords. So putting neocords, vortex neocords to the anterior leaflet and setting those cords at the level of the mitral annulus. So very rarely is resection utilized for the anterior leaflet. Almost always anterior leaflet prolapse is going to be addressed with neocords. So here is a post-op echo, and you can see that this has restored the Roman arch to this patient's geometry. So how to think about cord length, how to measure vortex. So there are several different measuring techniques for cord length, but I was taught a simple principle which works reliably, and that's to place the Gore-Tex neocords through the papillary muscle, and then after the ring is down, double loop the cords through the anterior leaflet in the zone of coaptation, or the rough zone, and then tie the cords down at the level of the ring or the annulus level. And if you're going to err on the side of too long. Too long is better than too short, because if you tie those cords too short, then you'll restrict the valve. Again, the key to the neocord length is setting it at the level of the annulus. So this is a schematic showing a flail anterior cord. And here you can see the placement of the Gore-Tex neocord into the papillary muscle using a figure-of-8 stitch. Some surgeons use a pledgeted stitch. And then once the ring is down, you set those aside, and once the ring is down, then you bring each arm of the Gore-Tex neocords back up and double loop through the rough zone of the anterior mitral leaflet side by side. And then you set those loops to the level of the annular ring, as you can see here. And then you cut the needles and tie the knot. Be careful not to shorten the length of the cords as you tie down. And so this is what it looks like in the end. So again, there are many techniques for mitral valve repair, whether it be neocords, triangular resection, quadrangular resection. And as you can see, the final product of all of these repairs looks nearly identical. As long as you reestablish the zone of coaptation or the keystone, then it should work. There is some debate over preferences for using neocords versus leaflet resection for mitral valve repair. Those that favor neocords in most scenarios argue that it is better to respect or preserve the native leaflet tissue rather than to resect it. However, the counter argument to that is that leaflet resection provides a very predictable and stable results that have been proven over many years with excellent survival and freedom from reoperation. And these results are reproduced over many studies. Many comparison studies have confirmed that both neocord and resection techniques yield excellent results for mitral valve repair. And more studies show the same results, again, citing that use of neocords can result in a longer zone of coaptation, but the long-term implications of this need to be studied. Both techniques have proven excellent and equivalent results in terms of survival, reoperation, and heart failure. But what matters most is, no matter the technique, fixing the mitral regurgitation. So again, the most important takeaway is that degenerative MR can be cured, but only if we leave no MR behind. As technology As technology continues to improve, more and more advances are made in the transcatheter world. The leading transcatheter technique for mitral valve repair is called TEER, which is transcatheter edge-to-edge repair. It operates with the same principle as that Alfieri technique that I talked about earlier, where the anterior leaflet and the posterior leaflet are essentially clipped together. Another common word for this is a mitral clip. This is the picture of what the device actually looks like. And the way it's done is using femoral venous access and then transeptal puncture. This device is advanced from the femoral vein into the right atrium and then across the interatrial septum into the left atrium where it approaches the mitral valve from the atrium side. It then lowers down into the left ventricle, crossing the mitral valve, and the two arms of this device grasp on the anterior leaflet and the posterior leaflet respectively, and essentially clip those two leaflets together at the site of prolapse or flail. Sometimes one clip is all that's needed, and sometimes you need more than one. And because of this, you do need to be aware of creating mitral stenosis with this technique. And any pre-existing mitral stenosis would be a contraindication to TEER. Also of note, this type of repair only approximates the leaflets and does not include any type of annuloplasty ring. So it fundamentally lacks that component of the repair. At present, TEER has the most utility for functional mitral regurgitation patients who have heart failure as the underlying cause of their MR. And these are fundamentally different patients than the degenerative MR patients and outside the scope of this talk. However, TEER is also used as a tool for high risk or prohibitive surgical risk patients who have degenerative MR. So as of now, there are no randomized controlled trials yet comparing TEER to surgical mitral valve repair. While TEER is a good tool for high-risk surgical candidates, early data comparing TEER to surgical mitral valve repair is concerning. As evidenced by this study published by Dr. Chikwe in January of 2024, which evaluated practice trends and 3-year outcomes from TEER versus surgical repair for degenerative MR in the United States. So she utilized Centers for Medicare and Medicaid Services data between 2012 and 2019, over 53,000 mitral valve interventions, either surgery or TEER, were performed for degenerative MR. And the endpoints were 3-year survival, stroke, mitral reinterventions, and heart failure readmissions. The volume of the total annual mitral interventions did not significantly change between 2012 and 2019. However, the surgical cases decreased by 1/3, whereas TEER increased. 3 years after TEER or surgery, stroke rates were similar, 1.8% or 2%, but heart failure readmission rates were 17.8% for TEER and 11.2% for mitral repair. And mitral reintervention rates were 6.1% for TEER and only 1.3% for mitral repair. Among Medicare beneficiaries with degenerative MR, an increase in TEER utilization was associated with worse survival, increased heart failure readmissions, and more mitral reinterventions. So randomized trials are needed to better inform treatment choice, especially for this patient population. So one major point that I try to emphasize to patients who are considering mitral valve repair versus TEER, or surgical mitral repair, is that it is flawed logic for them to think that they can try the transcatheter method first and then do surgery if TEER fails. The reason for this is that the clip adheres to the leaflets and it often causes irreversible damage to those leaflets. The rates of successful mitral valve repair after TEER are exceedingly low, and mitral valve surgery after failed TEER almost always results in mitral valve replacements rather than repair. So I just wanted to thank you all for listening and for having me talk today about a topic I'm so excited about. And thank you to Dr. Bowling for sharing with me a lot of the pictures and video, and for all the research and training we did together. And thank you to my new colleagues and mentors here at the University of Minnesota and fellows. So. Happy to take any questions.
Number one, that was so clarifying. I've always wondered what a mitral clip was, so now I seem to understand it. Thank you. The question I have is, if we wanted to do a randomized study to compare here to repair, what type of sample size do you think we'd use? Number one. Number two, do you think there would be problems in equipoise or having patients randomized to that? How would you overcome that?
Yeah, I think that's an excellent point. I think the lack of equipoise is knowing that mitral valve repair has such high standard and knowing that we already see these concerning signs for TEER. But I think, I don't know as far as the sample size, but thinking about TAVR and how they started with very high and prohibitive surgical risk would probably be the place to start. There was a new study, which I didn't include in this talk, that just came out, I think, in February of this year, that looked at mitral. It was a retrospective study, I believe, reviewing mitral valve repair in octogenarians, and basically showed versus TEER, and it basically showed that even in those octogenarians, the survival and reintervention rates, it basically reproduced these results. That survival was better for surgery, even though in those 80-year-old patients, compared to TEER with less reintervention. So, but I think in those very high risk and prohibitive surgical risk is where you have to start. But I'm happy to hear if there's any other suggestions on that.
One of the challenges is being present as surgeons for the initial evaluation of these patients, because if these patients are only seen by a provider who offers something other than surgery, I don't want to use the word, but sells that procedure without a surgeon, presenting the survival data that we know of, then the delivery of options gets skewed. So again, we're trying to encourage, the formation of valve clinics that a patient with mitral regurgitation or aortic stenosis can be simultaneously evaluated by different providers who treat the same disease at the same time. Allows for more, standard of care approach, as opposed to be biased to what you can do best.
Yeah, I think that's an excellent point. And even just having been looking around the country and meeting different people at different programs when I was looking for jobs, it's amazing how different the culture is at every institution. So for example, at Michigan, cardiac surgeons staffed every mitral clip. And we scrubbed into that procedure and did it with the cardiologist. And here we have nothing to do with it. And I think that there's a lot of reasons for that. It would be hard to staff, and so, but we are losing control of that. And I think it's really important. We still evaluate the patients in clinic for the most part. A lot of them come through our valve clinic. But with TAVR, it's a requirement that there's a surgeon visit and a surgeon present. But with MitraClip, that is not the case. Though with the transcatheter mitral valve replacements and tricuspid valve replacements, I don't know if it's a rule, but we're pretty much there for those. We at least back those cases up. But it may vary by institution how involved the surgeons are in both the preoperative patient selection and the actual procedures. So.
What's the complication rate with a MitraClip? Like if these are being used in people with prohibitively high surgical risk, if something happens during a MitraClip and you can't operate, like is it almost like universally fatal with like hemopericardium or something like that?
So it's a good question you ask. So MitraClips are not cases that, at least at this institution, that we routinely are available for backup. The case is a venous access and a transeptal puncture. So there haven't been that many instances, at least at this institution, where we've had to do bailout, unlike TAVR, which is fundamentally different. But at least when we have TAVR, when a surgeon has met with every single patient who's having that procedure, we always have a bailout conversation where we ask the patient's wishes in case and whether or not they actually would want to go through emergency sternotomy and open heart surgery. And sometimes I find that with these other cases, it's definitely a gray area because we could certainly be called in an emergency to come bail this out. And we wouldn't have had that conversation with the patient in advance just based on how it's set up.
Thank you. That was a wonderful talk. You mentioned that for asymptomatic patients who have, greater than 95% risk of a successful operation, they're still good candidates for it. How do you determine that they're above that percentage, and if TEER would be a good alternative for those patients who are below that 95% chance?
So I think I understand what you're saying. So basically, when you evaluate a patient, and maybe I don't understand, so I'll just explain. When you evaluate a patient for mitral valve repair surgery, you don't want to take that patient to the operating room for repair unless you're greater than 95% confident that you can repair the valve with a less than 5% incidence of having to replace the valve with less than 1% mortality. So I think most surgeons assess that from the echo preoperatively if we think that the valve is likely to be repairable. And so going in with that knowledge is how we make those judgments. And then if the valve is not repairable, then the patient may be either consider TEER if they are, older and maybe don't want to go through open heart surgery versus comparing that to a mitral valve replacement, a surgical replacement, or a transcatheter replacement, which is less common. Yes.
Maybe I missed this too. So what the indication for mitral valve repair replacement, in your opinion, is just the regurg, or is it symptoms, or is it, so what makes you?
So you have to have severe MR, and then if you have symptoms, that's a class 1 indication. And if you're asymptomatic, that's where the question lies. And so if there's evidence that the ventricle has reduced function, then it's already showing signs of the sequelae of chronic MR. That's an indication. If they have ventricular dilation, so an LV end stalk diameter greater than 40 millimeters, that's an indication. And then some less concrete indications is new onset AFib, pulmonary hypertension with PA pressures greater than 50, or in the truly asymptomatic patient with severe MR, if your chance of repair is greater than 95%, less than 1% risk of mortality, then you have a class 2A indication to offer surgery.
Even with a normal ventricle?
Even with a normal ventricle. Yes, that's the case, yes. And I think that, we think about it, if the ventricle is dilated, it's already had negative remodeling, and that patient is at risk of not getting back onto their normal life expectancy curve. We hope that once we've repaired their valve, that the ventricle can remodel down to size, and in many cases they do. But certainly the more dilation has occurred, the more the atrium's enlarged, the more AFib, the more tricuspid. It's just a big cycle. And the more of those things that have piled up for this patient, the less reversible it is.
So if you saw a patient that had none of those things, had regurg, they said, "Oh, now would you even do it for them?"
Yeah, if they have severe MR, yep, because again, the natural history is that almost all patients with severe asymptomatic MR will progress within 10 years to either death or surgery. And so I don't think that this is a condition that reverses. It's a matter of time. And as long as you're confident in your ability to deliver an effective repair with low risk, then you're justified, and probably it's a good thing to offer this patient surgery before they go down the road. Yeah, complications.
I have one last question. The different etiologies for MR. If you think about maybe, is it rheumatic heart disease or other features? Do any of the different etiologies in true MR, not functional, have a a different response to the repair?
Certainly. So yeah, if you have rheumatic heart disease and more restricted leaflets, it is difficult to get a successful repair. So this is something that comes up more in developing countries where the question is what to do with those patients. Are you going to do a replacement, mechanical valve, tissue valve, or are you going to try for a repair? And there's a lot of debate over that topic. But I think the question is how advanced and how much leaflet damage is there, and when you're in there making that assessment as to the adequacy of a repair versus leaving a patient with mitral stenosis after you've done a repair with leaflets that are not fully mobile. So there's a lot of debate on that topic, but in general, rheumatic valves not usually repaired effectively.
Thank you very much. It's been a really fantastic talk. Obviously, as you know, I was at the University of Michigan in the cardiac ICU, and a lot of your pictures made me very nostalgic for that time. I think it's, we're very lucky to have you here. I think a lot of these techniques and the things that you're bringing really enhance the work that we've been doing here for a long time. And so we're glad you're here. I do think that What Works would be a great name for a podcast. So you should go ahead and continue to do that. That was the title for the talk, What Works. So thank you very much.
Thank you.
Oh, yeah. Yeah.